Hi everyone, I'm here with Dr. Boyan, the cardiovascular surgeon for the University of Michigan. We're going to do 3 questions about his technique about the Y-incision in aortic root enlargement.
Thank you for inviting me.
Oh, my pleasure. So the first question is, in the long term, what the most promising outcomes have you observed regarding to the durability of prosthetic valves implanted using the Y-incision technique, especially in preventing patient prosthesis mismatch and its hemodynamic impacts?
Yeah, so the Y-incision annular enlargement is a simple, effective technique to upsize the valve by 3-4 valve sizes. And the valve opening is much smaller than the label. By doing this, basically we have a valve with opening, matches the patient's native aortic annulus, give the patient the best hemodynamics. The Ross procedure works so well because the pulmonic valve matches the aortic valve opening. This can achieve that goal, but much simpler operation. We only have 5-year outcome now, but it shows promising data for hemodynamics, the EOA, the gradient, and also the LVH regression. It's very impressive. It's 40% in 1 to 2 years LVH regression, and the patient feels so much better. We'll follow those patients for long term. Hopefully in 10, 15, 20 years, I will have long-term results report. But so far, the hemodynamics is so much better.
The second question is, despite the excellent initial results, are there any specific patient types or anatomical conditions in which the Y-incision technique presents greatest challenges or limitations? If so, what specific surgical considerations arising in those scenarios?
That's a very good question. And the Y-incision, I think we should apply to any patient with the annulus from 17 to 25 millimeter, because above 25 is dilated annulus. You can put a 27, 29 valve without enlargement. From 19 or 17 to 25 millimeter, we should enlarge it. And the 29 size valve has an opening about 23 millimeter. That's determined by FDA, by valve company. That's no question. So to me, and I think to all the surgeons, any normal annulus 70 to 25 millimeter needs an enlargement. More important is for women. The mean annular diameter for women is 21 millimeter. So vast majority of women have small annulus. So, and at the New York Valve meeting, TVT just finished, the vice president of ACC just told me a lot of women have not got large enough valve. So this technique, it's really important for women too, and more important. But for men, and we have a study showed in men with the stenosis, aortic valve stenosis, only those got the size 29 valve have their long-term survival match the general population. I'll show the data at this meeting too. So I think both men and women with the normal annulus should have enlargement. That's why 75% of our patients have enlargement. And the second question, technical challenge, who cannot have this enlargement, is the patient who has full thickness calcification out of mitral curtain. When you cut open the old mitral curtain, there's nowhere you can stitch the patch. For those patients, I do not do, only have one patient like that. Second is patient has aortitis. If you enlarge the root, it could develop a root aneurysm. So I didn't do for those 2 patients. So keep those in mind. One, full thickness calcification of aortic mitral curtain. Second, the aortitis patient.
In the last question, with the increasing of the development of transcatheter approach, surgery TAVR, how do you see the role of the Y-incision technique, especially when combined with the root technique in the open aortic valve replacement? Do you consider it a complementary or a primary strategy for specific patient profiles who may need reintervention down the line?
Yeah, That's a great question. I think that's related to lifetime management. TAVA and SAVA should be complementary. It's not competing each other. It should be two tools in our toolbox to help the patient the best, which means for patients that no risk patient, they can live longer, more than 10 years. We should do SAVA, especially younger patients, say 60, 65. You do SAVA with the enlargement. And the Y-incision enlargement the end of the root. So the root about 40 millimeter, increase the valve to coronary distance, increase the valve to aortic distance, enlarge the STJ, as you mentioned, the roof technique. So down the road, it's very easy to put the valve in valve TAVA. Think about it, patient that's annulus 23. Instead of putting a 23 valve in, put a 29, enlarge the root. Then you have about a 4-5 millimeter distance between the valve and the coronary, and between the valve and the STJ. You can easily put the valve in valve TAVA in the future. In patients like 75, 80 years old, then give patients another 10 years. So basically, we can extend the valve longevity, like total about 30 years. Because when you put a large valve in, the opening is bigger, right? And the valve gradually calcifies, getting smaller. You have large opening, takes longer to get to critical stenosis. That's why the large valve lasts longer. So we are following those patients for their quality of life, longevity of the valve, and down the road the feasibility for valve in valve TAVA. We published a paper too, with all the CT scan, post-operative CT scans, did all the TAVA measurement. The geometry, the measurement are very, very fit, very feasible for future valve in valve TAVA. That's a great question.
Thank you.
You're
Thank you so
welcome.
much for your interview.
Yeah, you're welcome.